Basically, this is a safety and efficacy of diagnostic studies for ruling out pulmonary embolisms. A systemic review. But bottom line is they looked at a bunch of basically pulmonary embolism heart score equivalents on how to rule them out. But they also looked at the efficiency of these studies. And it was defined as a proportion of individuals classified by the strategy as PE considered excluded. And they looked at the various imaging tests. Bottom line was, overall, all the strategy shows acceptable safety with pretest probability dependent D-dimer thresholds, having only the highest efficiency. So the most efficient way to rule out a PE was to get a D-dimer. And if your D-dimer was negative, age adjusted, you were safe to discharge that patient. But it also had the highest predicted failure rate, which means that there was a number of people who, which doesn't make any sense because they said it's the most efficient, but it also is the least sensitive. So it really what they said is it's most specific, but it's the least sensitive. From an overall efficiency perspective, though, on the individual patient, basically they said even though you're going to miss some with the D-dimer, you might as well go ahead and use it because that's the most efficient one. My own feeling is that kind of makes sense, and I was listening a little bit to Ken talk about this with the PEs and the COPD patients, and that is they're people who they're going to come in and you're going to say, I'm not even ordering the D-dimer. You just such have a high risk probability. You know, you have cancer, you broke your ankle, your leg's in a cast, and you're short of breath. You know, I'm not wasting time getting you a D-dimer on you. But the average garden variety patient who comes in, they have pleuritic chest pain and they're a little tachycardic, you can rule them out safely with the D-dimer. Yep. Oh, way before COVID, yeah. You can just throw your D-dimers out in the setting of COVID.
There's a lot of PEs, there's like astronomical D-dimers, so do you have any?
Yeah, I personally, having coded two people who were relatives of, one was one of our nurses, our former nurses, and one was the husband of one of our PAs who had COVID, a rocky COVID course, and then came back like 2 weeks later and coded. From their PEs, both had emboli. I consider COVID in the same category as a lower extremity immobilization and cancer. You've got a PE until proven otherwise.
Does the D-dimer help you decide?
No.
Whether to CT them or not?
Nope.
They're astronomical.
Nope. Just the problem with the PE, with the D-dimer is even if it's negative, I'm still getting the PE. I'm still doing a diagnostic study on them.
Could you restate the question here?
Oh, I'm sorry. Yeah, the question was, what are we doing with D-dimers in the face of COVID patients, COVID positive patients? Because the concern was that they're markedly elevated in these patients, and some of them have PEs and some of them don't. And it may just be secondary to the COVID infection. But the reality of it, my response still stays the same. The disease itself is such a high risk for pulmonary embolism, especially if you're a couple weeks out from the disease. That I just tend to just go ahead with the diagnostic study and skip the D-dimer.
Right. Abstract number 24. This is the risk for recurrent venous thromboembolism in patients with subsegmental pulmonary embolism managed without anticoagulation, a multi-center prospective cohort study. So a little background on this. There had been some evidence previous to this paper that potentially you could get away with doing some form of algorithm in patients with subsegmental pulmonary emboli in such a way that you might not need to anticoagulate them, and that algorithm would involve some form of doing ultrasound studies of lower extremities, and if those were negative on like subsequent visits, then you may be able to avert having to anticoagulate these patients. So these authors took a look, did a multi-center prospective cohort study. They enrolled 266 patients with subsegmental pulmonary emboli, and they used the primary outcome of recurrent thromboembolism. Did these patients, despite not being anticoagulated, develop a recurrent thromboembolism, some sort of DVT or anything like that? And what they found is out of that cohort of 266 patients, 8 of those patients, so about 3%, ended up developing a recurrent thromboembolism was higher than expected. And then when they looked at the subset of patients with single subsegmental PE versus those that had multiple subsegmentals, the numbers were 2% for single subsegmental, and about 6% of the multiple subsegmental PEs developed recurrent thromboembolism. They actually, in this observational study, they applied part of that algorithm. So you got diagnosed, you have a subsegmental PE. Now, you go on to get bilateral lower extremity ultrasounds. If that's negative, you get a repeat in 1 week, and then they would follow them out to see if they eventually developed a thromboembolism, and a higher number than expected did. Their conclusions were that patients who did not even have an initial proximal DVT on bilateral ultrasounds over the course of a week, those patients still are at risk for developing a thromboembolism and likely should be anticoagulated.
The title's a little misleading because it says managed without anticoagulation. Is it these people had, they were diagnosed with a PE and they weren't
Correct.
Managed with pulmonary with any anticoagulants?
That's correct. The ones that were observed, they put them through the algorithm. They got a subsegmental PE, not anticoagulated, if they didn't have a proximal DVT on their ultrasounds. And then they repeated that ultrasound. If that was negative, they kept them off anticoagulation and they followed them 90 days out. This is interesting. I mean, we're going to be talking about isolated distal deep venous versus proximal DVTs in the next study, which was another space where people were holding off on potential anticoagulation. But in this, I've not ever in my practice not anticoagulated a PE. That's me. And this study just further emphasizes that for me. Other folks have different opinions about it. Any physician-to-physician variability on the panel?
Yeah, that's what struck me is like we sent home a PE without anticoagulation. I'm like, okay.
Yeah, no, I'm anticoagulating these people, and you know, with DOACs now, it's been so easy to do that.
Yep.
So,
25? It's a similar topic. Now, this is a challenge of our belief that distal DVTs are safer than proximals in terms of propagation, embolization, and recurrence. And this is a large study, a database study. Interestingly enough, the Mayo Clinic Gondo Vascular Center was part of this thing. Mayo Clinic, the Phoenix Mayo Clinic Hospital is right on this road that you came on this freeway. And I don't know if you, when you go back, ask your driver to show you where it is. It's a huge complex, which is becoming huger. They've got one of these cranes out there, and they're making another hospital the size of the one they already have. So, one other thing regarding Mayo Clinic. I saw a listing yesterday of the top 25 hospitals in the world. Mayo is number one. Now, the Rochester Mayo. This is like Mayo Junior kind of thing, you know. Tomorrow we're going to have a physician who works at the Mayo ER with us. I have to get back to this paper, I guess. Now.
Yeah.
The patients were divided into two groups in this study. The ones who had proximal and those who had distal. There were a large number of patients in this this study. Let's see here. Oh yeah, distal 746, and versus proximal 1,176. This is a huge numbers. Now, what was the consequences here? Isolated DVT, distally, was more often associated with recent surgery, major trauma, or confinement, whereas proximal DVT was more frequently associated with, was unprovoked, number two, prior history of VTE, or cancer, was the proximal ones. What about outcomes? There was no overall difference in the outcome with regard to recurrence or major bleeding between the two groups on follow-up. The distal had a higher death rate at 3 months, which was statistically very significant. However, we're talking about, you know, a registry kind of thing, so you can't necessarily say, well, that was the reason. Independent predictors of mortality included warfarin. Yeah, that drug is, that's had it. The DOACs, increasing age, and active cancer. So this paper says that distals are not so benign in terms of what you think with regards to recurrence, bleeding, and whatever was the third one thinking?
Death.
Death, yes, death.
Yeah, that's the third one.
Inconvenient outcome.
Changes our thinking a little bit. Proximals are safer, distals are safer, proximals more dangerous. Not according to this.
Yeah. This is interesting. I have a colleague right now who's in the middle of a lawsuit for this very issue. They chose for a distal DVT based off some prior evidence that he just didn't anticoagulate, and they opted for the patient to return for a repeat DVT study, and the patient ended up developing a PE and had complications and whatnot. So
Yeah, that strategy always kind of made me a little weird where, well, we know it's in your calf. We're looking at whether it's going to move. So come back in a week and we'll do another ultrasound to see where, oh, by the way, now it's up in your thigh. Or
They don't come back.
or it embolized before you did this 1 week repeat. It's like,
But the current guidelines don't, that's what they, your colleague was following
yeah,
the
exactly.
current
But they're weird, they're
guidelines
wacky.
to guide them, and you're not supposed to anticoagulate between the two ultrasounds.
right, and this was we talked about this at one of our rounds recently, and he was saddened to learn that in 2020 Cochrane made a statement like based off all the available evidence that in fact we should be anticoagulating distal DVT, and Cochrane is almost always like
Very conservative.
Very conservative, and so when he saw that study, he's like, oh, geez.
But when did he see the patient? Before 2020?
No, recently.
Oh, okay.
Yeah.
Yeah. Now, like guidelines, it's in there in the name. They should
trust
guide your
guidelines.
care.
Yep.
Right? They should guide your care. They don't dictate your care. And, taking practice from just an algorithm to using your brain is, okay, the guidelines say, it's in the calf, whatever. And if you got a D-dimer and it's through the roof, I'd be having a longer conversation with that patient about that. Do you want to anticoagulate?
Sure.
I mean, you look at the superficial thrombophlebitis, and they're using, what's it called? Fondaparinux and stuff like that for 45 days. So I don't know, like you've got to risk stratify it for each patient.
Yep.
Well, I hope, how far is into his suit is he? Because,
He just got word.
oh,
that,
great.
risk management contacted
There's a
him.
piece of your liver.
We'll see where it goes. But yeah, I mean, this is the problem. Like, almost in his case, it was a matter of him knowing too much, but not.
Didn't
all-
follow the community
but-
standard.
Right.
No, didn't they follow the community standard? Wouldn't that be the community standard of a distal DVT?
It was a distal DVT, so per some evidence, yes. and
distal DVT, and bring you back in 5 to 7 days.
I think-
repeat the ultrasound.
I think the problem was there was no shared decision making
Oh.
in that process.
Yeah, you
either,
just-
so the
Oh.
patient had no.
You know,
like,
we're doing
understanding of
a talk on shared decision making,
Yeah.
and the legal consequences of decisions in terms of bringing the patients into what you're going to do and get them some buy-in. All right, moving on ahead.
Okay, so we're going to switch from adults and PEs to kids and pneumonias. And this is a really interesting study. It's a trial called the SAFER trial, so it's in the acronym. And it's talking about a short course of antibiotics for well-looking children with community-acquired pneumonia. Do you treat them for 5 days or 10 days? And so it was 2 centers.
0 days.
Parallel group, and it was a non-inferiority study, because what they were trying to figure out is 5 days non-inferior to treating with 10 days of antibiotics? This was done in my own province at McMaster University, where evidence-based medicine was sort of first ramped up back in the early 90s with Gord Guyot and Dave Sackett. And then the Children's Hospital of Eastern Ontario, or CHEO, which is in Ottawa. And what they did was they took these children, and both the clinicians and the children and the parent were blinded to group allocation, and they either got 10 pills and 5 of them, or 10 days, sorry, and 5 days was high-dose amoxicillin clavulanic acid, and the other group, the standard care, was 10 days of full-on high-dose amoxiclav. And what they were, the children had to have a a cough or respiratory symptoms. But interestingly, they had to have a chest x-ray that showed pneumonia. Now, the American Academy of Pediatrics says for kids, and kids in this case was 6 months to 10 years of age, you don't need to get a chest x-ray, okay, to make the diagnosis of pneumonia in a child. But they had chest x-rays. They got into it. 5 days versus 10 days, and the outcome was, did they have a clinical cure in 2 to 3 weeks? And they got close to 300 children into this, and they found that 90% of the kids in both groups had a clinical cure. 90%. There was a 1.6% difference. Now, this was a non-inferiority study, so was it non-inferior? And they looked at the confidence interval around that point, and they said if it spread out to 7.5% difference, if it was beyond that, they'd say, well, it's inferior. And it actually was, I think, 8.7%, so 1.2% difference with that. And so they can't formally claim that 5 days is non-inferior to 10 days. I clinically interpret that as, when I'm talking to parents, hey, 90% of kids will do well. They'll do fine with 5 days. 90% of kids will do fine with 10 days. What would you like to do? Because they're on amoxiclav, which is basically amoxicillin with diarrhea. And, that's the added bonus. And so, you look at the parent and you say, and if they say, oh, everybody in my family's had these allergies, and there's minimists, right? Parents are like, oh, I don't want Johnny to have any antibiotics. He's never had antibiotics before. And you've got the other parents that are caregivers that are like, oh my God, no, 10 days, full on, and everything in between. And so I do a shared decision making around this issue now and say, well, traditionally we've used 10 days, 5 days seem reasonable. What do you want to do? And then I document it.
What about in this trial having no days?
So Dr. Pekarn, that's Dr. Nathan Cooperman, but I call him Dr. Pekarn, from the Pekarn group, when I did a podcast on this and tweeted about this episode, Dr. Cooperman, Nathan, got a hold of me through Twitter and said, hey, Ken, you know what we're doing now? 0 days. A study of 0 days versus 7 days in a well-appearing child who's got community-acquired pneumonia, who you're planning to discharge and has a low procalcitonin. That's their study. And they're doing 0 days versus 7 days. And as soon as we get those results, he's going to come on the show and we'll do a podcast on 0 days. Because the vast majority of these children have viral pneumonias. Even if they have bacterial pneumonias, we don't have good evidence that an antibiotic makes a clinically important difference.
Yeah, wasn't there a guideline that said kids under 5 or 6, they don't get any antibiotics for pneumonia? Al, am I making this up?
Yeah, you're making that up.
Yeah, I don't know about a guideline that says that.
Yeah,
All right,
no, it
well-
was the big thing was under 5. They didn't get mycoplasma was the thing, and you shouldn't give them a
Macrolide.
Macrolide type antibiotic.
Oh,
No,
I don't
they always
know.
got it. Yeah. Well, actually, move on to 27 because
Yeah.
27 is the exact same study, only they took it down to 3 days, so that they were getting towards 0.
This is the capit.
Yeah. So they were moving towards 0. They used the same thing. They randomized. Only these guys used amoxicillin, so they were even more gutsy. So they
Well, they're in the UK.
yeah. So it's 3 days duration was not inferior to 7 days. The only difference was the cough got better if you extended it to 7 days. So the 3 days, they were still coughing back then. But I agree. I think we are moving towards 0 days. The only problem is, in all honesty, if mom brings Twinkie in and the kid's got a cough and they're febrile and I'm worried, I can get an x-ray and start them on amoxicillin and send them out and they'll be done in 3 days. If I send a procalcitonin to decide whether to make it 0 days or not, the kid's going to be there for a month waiting for the results to come back. So you have to have a shop that can turn around a procalcitonin in the same time it takes to get an x-ray, yeah.
But there is another study that was published just January, I think, in JAMA Pediatrics, and it was the SCOUT CAP trial. So it was the short course versus standard course of outpatient antibiotics. And again, it was a 5-day versus 10-day thing. And again, the results were pretty much in line with it didn't matter.
Right, and I think you're right. I think it's because most of these kids have viral
Viruses.
infections, yeah.
Yep.
All right, moving on to abstract number 28, interventions to reduce arterial puncture-related pain, a systematic review and meta-analysis. This was published in the International Journal of Nursing Students, I think.
Studies.
Studies,
I think.
yeah.
I like
Not
students.
Not
I like
the-
students better.
Not the national, it was the international.
So this was basically a systematic review, meta-analysis of all the different ways that we can help prevent ABG-related pain. They looked at a bunch of different studies with different interventions. The interventions included local anesthetics, cryotherapy, topical anesthesia, and then they looked at whether if we used ultrasound or if we used a narrow gauge needle, if that could help. And what they basically found was of those interventions, the studies showed the best benefit with local anesthetic sub-Q prior to doing the ABG. That seemed to have the best impact. And then cryo and topical anesthesia came after that. It seemed, interestingly, ultrasound guided, although it helps you to find it, maybe avoids more pokes, doesn't really makes sense. It doesn't really avoid the pain. And the narrow gauge needle didn't seem to have much benefit either. But again,
The one thing people have always taught me about this is we numb the skin up, but the real pain of it is, in addition to the skin, there's a lot of nerve fibers that wrap around that artery. And that you want to go down deeper with it, or go sub-Q, and then squash the living daylights out of it to get the anesthetic down around the artery itself.
in which case it might make sense to do the ultrasound so you're not accidentally
Yeah.
hitting the artery. But
Well, then if you do, you just take
Yeah,
the
take
syringe
it out
off
and
and you
that's why
collect
you're
the
pulling
specimen.
back.
Yeah,
then you're done.
you're done.
So I'd like to,
Are blood gases still being done?
Well, that's the other point. How often should we be doing these ABGs? But we're doing a lot less of them in our shop for sure.
But you know where it makes a difference though is we're putting a lot more arterial lines in the emergency department. Yeah.
We don't.
And it makes it, the first go, you're going to use the ultrasound for it. Number two, you really have to numb them up, although half of them are comatose anyway.
I'd like to draw out like little pearls from the methodology from various studies. And when I was looking at this systematic review, whenever you're looking at a systematic review, you'll see a forest plot with all the little boxes and whiskers and then a diamond down at the bottom, and it's like, look for something called the I-squared test. The I-squared test is a test of the heterogeneity. How different were the tests that they were, or the studies that they were trying to mash together in the systematic review? And it goes from 0% to 100%. So 0% is like, an outcome of death, and it's pretty objective, and everybody agrees, yeah, they're dead or they're not, right? And then on the other end of the spectrum, a heterogeneity of 100%. That's not apples and oranges. That's like comparing apples and bagels or something like that together. And if you looked at the heterogeneity of these studies, they range between 79 and 91%, questioning whether or not you should have just actually done a qualitative assessment, a narrative assessment, rather than actually doing a mathematical assessment of these studies. The only thing that had a 0% was the local infiltrate. And that was what they had the best evidence for, right? And so the rest of it, I'm like, yeah, no, I don't buy it. But I buy the local infiltrate stuff with the 0% heterogeneity and low risk of bias. There, I bored you.
Yeah. So try not to do ABGs, but if you have to, sub-Q.
Yeah, and that's, yeah.
I would think that in a residency, that it would still be rather common to do them. Just
Far less common. We're rarely doing them. In fact, we have the capability to do REBOAs and all those kinds of things for the traumatic arrest, in which case they want arterial lines, but we still haven't been able to get the approval to do A lines or anything in the ED.
Really?
So we're very rarely doing
We
it.
do, I mean,
It's the RESP techs that are coming down and doing the...
Yeah. Yep. The respiratory techs are.
Those are the
they
ones
do
that
the
are
blood
doing,
gas.
oh, you want an art?
The docs put
gas?
the A-lines. I mean, pretty much anybody who's, falls into that sepsis protocol, it's so much easier for the nurses to do, because that automatic blood pressure cuff, when the pressures get to like 70, it's not working that well, so.
Yeah.
29? The comparison of IV Ketorolac at 3 doses, you know what the answer is already, for treating renal colic in the emergency department in a non-inferiority randomized controlled trial. They did 10, 20, and 30 milligram doses in adult patients presenting to the emergency department with renal colic. They had 165 patients, that's a lot, 55 in each of the 3 groups, and improvement from 90 minutes at baseline to, went from 90, that was the pain, at baseline, to 40 after they got the Ketorolac. And this improvement was 40, 50 in the 20 milligram and 10 milligram doses. So basically, what can we say about inferiority? I mean, basically, every one of these papers comparing Ketorolac says once you get over 10 milligrams, you're basically, you've hit
The ceiling, there's a ceiling effect to it, yeah.
analgesic ceiling, and
talked
you
about
may
this
be
yesterday.
into more anti-inflammatory effect or up there.
And it'll last longer the higher the
More,
dose.
more GI effects and those kinds of things, or and it's true with the oral NSAIDs and
But with, I think the Ketorolac has an interesting twist, because what drug do we use parenterally that takes 3 times as much? Like a 30 milligram, we were always giving 30 milligrams IV or IM for
Or
Ketorolac,
60.
or 60, right? And the oral was 10. Huh? Isn't that the opposite of what you would expect? So why would it, we're injecting it. So it never made sense to me, but there's a ceiling effect. Once you get above 10, you're okay for analgesic effect.
This is an Iranian study. They are obsessed with checking in Iran about.
kidney stones.
I'm Persian, so I can say this, but kidney stone pain, yeah, and non-opiate. They did the same. These were, it was out of
Same
Iran,
group?
the lidocaine studies and all that kind of stuff. Interesting.
A center of excellence.
Yeah.
With stones. All right, well, I've got number 30, and this is looking at stones. Can they be safely excluded on a contrast CT? That's the question they're asking, and to answer the question, they're using a retrospective analysis. And so all you can determine from that is associations, not causation. And so they took patients that had flank pain, and they retrospectively looked at the cohort and quantified the negative predictive value for ruling out a kidney stone with a contrast CT versus a non-contrast CT. Now, it was a single center, but they had multiple academic sites. And like I said, they had to have flank pain, 200 consecutive studies in both contrast and non-contrast. And negative predictive value, it's important to know that that's based on prevalence, right? So if you have no disease, your negative predictive value can look like 100% because nobody had it. You see this with the CT head studies and stuff like that. If you're scanning every single headache that comes in, the negative predictive value is like 100% because nobody had it. So in this case, a lot of people had stones, so the negative predictive value is useful. And what they found was that the prevalence was 44%, right, in the prevalence of obstructive stones in the non-con. So if you have a patient that comes in and you go, listen, I really think this is a kidney stone, we just need a non-con, 44% had it. In the contrast CT, right, half that had it, just less than 20%, because you weren't so sure. But in both cases, you can rule out an obstructive stone even with a contrast CT. And that's what they were trying to answer. And so my approach to this is, if I know that it's a stone, right? I mean, hey, I've been here 18 times, you look in their chart, it's like they're coming in every so often with a, doing the hippie shake and holding their flank and throwing up, and they're like, yeah, it's back, right? I'm not getting a contrast CT. I might not even get a CT, right? But if it's like, they've got flank pain, I'm not sure. I've been fooled before, and it doesn't look like a duck, walk like a duck, quack like a duck. Hey, I'm getting the contrast CT because there's other things I'm interested in finding that a non-con won't give me. So
It's particularly helpful in older patients where it's hard to know what the because
they're nasty.
I love knowing that.
They fool you.
Yeah.
I've been fooled. Like 99-year-olds with appendicitis coming in with right flank pain. I'm like, really? Right?
It's more the aneurysms that you get fooled for. Yeah.
Yeah. And the other thing is, and if they come in and it's like, I know that it's probably a kidney stone, we've got good evidence that an ultrasound
Yeah.
is just as good for ruling out badness, like bad obstructive disease, bad outcomes and stuff like that, as a non-con CT. But if I have diagnostic uncertainty, then I'm getting the contrast CT. And yet, like you said, older individuals. Yeah, absolutely.
Older individuals, I don't go down the ultrasound.
No.
route. If I
Well, there's
have
a nice
diagnostic uncertainty.
Yeah, there's a nice algorithm for that with regards to that that's been done on, and I think it's the Radiology Society, the Emergency Medicine Group, and the nephrologists or urologists, sorry, have come together and put together a statement saying that ultrasound is okay in select patients.
Yeah, that, except for all the practicing urologists don't agree with it.
Yeah, of course.
Yeah, and so, yeah.
There's controversy in the
Exactly.
world.
Yeah, you say I got an ultrasound of this person, looks like they have something. What's CAT scans go? It's like the ultrasound shows the stones. Go. Well, they're going to need. If I see them in the office, they're going to get a CAT scan
no,
anyway.
exactly, yeah.
Okay.
Yeah.
We just won't send them to the office.
Yeah.
Well, it's a perfect segue for the next paper.
Yep.
Hydronephrosis severity clarifies the prognosis. This is actually a very interesting study. What they did is that they took a bunch of people who had CAT scans and demonstrated stones, and then they went back and they looked at the degree of hydronephrosis to see if that would predict who was going to pass the stone and whatnot. And what they found was kind of fascinating. If you had no hydronephrosis, the passage failure rate was about 15%. If you had mild hydronephrosis, it was about 20%. And then if you had severe hydronephrosis, 43% of the time you weren't going to pass the stone. And when they went back and looked at it, it was almost like a retrospective look back, because the larger the degree of hydronephrosis turned out to be the larger the stone, correlated with the size of the stone.
Duh.
Which is then correlated with whether you were going to pass it
the
or
stone or
not.
not.
So they actually made it, they said, if you have severe hydronephrosis, they're not passing it, just throw in the towel. If they have mild or moderate hydronephrosis, or they group them as moderate, severe, and absent mild. If you had absent mild, they're going to pass it, just send them home, they're going to do fine. If you had moderate or severe, you probably should risk stratify that person. They're probably not going to pass it, and you need to get urologist or your urologist or whoever, or interventional radiology involved a little bit sooner.
Anybody have anything to say about it?
I just have a question. Did that study show any, measure the size of the stones at all?
Yeah, they just said larger stone.
what was
They
the
didn't.
question?
They didn't put a. The question was,
Greater than
did
5.
the study show anything about the size of the stone? And the answer to that is, the severity cases had greater than a 5 millimeter stone, but the study itself wasn't looking at that. But it did correlate with the size of
It
the
was
stone.
sort of binary. They looked at
Yeah.
greater than 5 millimeters, or like
Yeah.
large, greater than 5, and less than 5, not large.
Yeah, and usually when I'm talking to these oh, sorry.
Go ahead.
How long, if you have severe hydronephrosis, how long do you have before you knock off that kidney? Irreversible kidney.
The question is, if you have severe hydronephrosis, how long before you've allowed that kidney to basically become non-functional and you've killed the kidney? That's really variable. It starts with what the kidney looked like beforehand, what was the kidney function beforehand, but and it goes on from there. I don't think there is a fixed amount of time that someone can say, oh yeah, if you have severe hydronephrosis, you have 2 days to decompress the kidney before they have loss of function of it. I don't know that there's ever been a study that gave you that much time. I think what people will tell you is there's a sense of urgency if you have severe hydronephrosis, particularly if you have leakage around it and it looks like you've ruptured one of the calyces or something like that. But I don't think there is a number I could give you that would say, oh, this is the, you have 2 days before there's a problem. You guys have any other information on that?
No.
Well, yeah, it takes place in the context, right? Like, just what are their other comorbidities? What other medications are they on? What time of day is it? What urologist is working? These all come into the sort of the clinical milieu of how urgently will they be seen, right? But there is a sense of urgency, but I don't think you can set your clock to it like Al was saying.
But I wouldn't be super concerned about like a young patient with a 3 millimeter stone with a little bit of hydro that they end up having hydro for a little while and then they don't, I think.
Yeah, but it's the severe hydro, the
those
diabetic, the
ones,
65-year-old,
those can be-
hypertensive. Yeah.
And do they have a concomitant UTI? And
Yeah.
More times than not, though, if they have the severe hydro that you're talking about,
They're sick.
they're too ill to go home anyway.
Yeah.
So that you're going to wind up keeping them, and if they're febrile or something like that, you're going to get a stent put in or a perc percutaneous nephrostomy tube, probably within that day.
You know, on a related matter, we did an interview with Dave Talon, who's one of the infectious disease emergency physicians, and the issue was a discussion about people who have kidney stones, and we just generally look at, well, is there blood in the stone? And we don't look at the UA necessarily. And he has brought up multiple cases where people have gotten into septic shock because that initial urine that they had evidence of an infection and was not recognized. No preemptive treatment was done. And his position is, if you have any evidence in that initial urine that there's more white cells in there ought to be there, that it would be the appropriate thing to do to start those people on antibiotics based on the fact that he's testified in a couple of these lawsuits, and other people have said the same thing. So it's a word to the wise, because I must admit, I just look for blood. Blood there, you got it. You know.
It's about a 10 to 15% like false negative rate on those urines. They actually, one of the only studies I've ever seen in the ED on identifying UTIs in the setting of kidney stones came out of UCLA, where Talon works. One of his colleagues published a little sort of associated factors, and that had to do with like being female and the number of white cells in your urine and that kind of thing. But there's no great evidence, which is a bummer. Like, you wish you could just say, like, if only there's this many whites on your urine or this thing, but like there's no perfect tool like that. So
But
there's a lot of clinical judgment in there.
I'm very conservative with that. If I see any, anything over 10 white cells, I'm very, very conservative with that. And the other thing is, you can get burned and your urine can be perfectly clean with no red cells, no white cells, because if you have a total obstruction, nothing's there, and everything's backed up into the kidney itself. And then 100% of the time, if they're febrile with a kidney stone and have any degree of hydro, they need to come in, because you got to get rid of the hydro in that person. Either you put a stent in them or something along those lines.
And since we're talking about, urines and, kidney stones and people coming in, if they had a history of kidney stones and they're coming in and it looks like a kidney stone again and it's acting like a kidney stone again, and they've got a little bit of blood in their urine, I'm still putting on my ultrasound probe on that aorta, and just going, yeah, okay, good. Because, older, and men over 65 are supposed to be screened for AAAs if they're smokers and stuff like that. So if I've got, it's so easy just to take the probe and go, yeah, okay, it's probably a kidney stone. Okay, yeah, no, your aorta's fine. Because
Sneaky.
that's not the one you want to miss.
So continuing on with the urology theme, abstract number 32. This study is called The Effect of 7 versus 14 Days of Antibiotic Therapy on Resolution of Symptoms Among Afebrile Men with Urinary Tract Infection, a randomized clinical trial. This was published in JAMA 2021. This was done in the VA, at two different VA hospitals, I believe in Minnesota and Houston. They basically took males with UTIs, about 270 patients. They randomized them, and this was a double-blind, placebo-controlled, non-inferiority trial like we had just discussed. And they randomized them into a 7-day arm or a 14-day arm. And they did a nice job with the placebo effect. They gave 7 days of either Bactrim or Cipro to the 7-day arm. And then for the 14-day, and then they gave 7 additional days of placebo. So you wouldn't know if everybody got 14 days of something, but the one group got 7 days of placebo additional, and the other group actually kept going with their Bactrim or Cipro. And then they looked at symptom resolution at 7 days, 14 days. They looked at recurrence. They looked at adverse events. And it turns out that statistically the numbers were fairly similar. The 7-day group had actually more symptom resolution somehow. So it had 7 days, had 93% symptom resolution, 14 days, 90%. Recurrence was about the same. Adverse events were similar, except a little bit elevated in the 14-day group, as you would expect. The conclusion by the authors here is that 7 days for a male UTI should be approximately equivalent to a 14-day course. I typically am not given 14 days anyway for UTI, so I mean, this is a clinical question that just
Again, I was reading this one and I was like, geez, are people giving
right?
2 weeks worth of antibiotics for men with UTI? I mean, I haven't been.
Well, I thought there was an issue of, well, is this a little bit of a prostate problem?
Prostatitis.
And
Yeah.
traditionally that is treated longer. But every test, every study that starts out with X days versus Y days. It's always choose less. Always choose less.
And it's interesting, and I don't know if I would have liked to see a study design where they excluded patients with fever, and you always want to look at, like, is the population that I'm going to apply this to the population that was studied? And they actually excluded febrile patients, so
Yeah.
you could argue that febrile patients we don't know if they need more or less. It's a bummer they excluded them, because I don't know if even febrile patients, unless we thought they had pyelo or something else going on.
I just like traditionally, why did they pick 14 and 7 days?
Yep.
You know, like, where did that number come from? Did they do a duration study to figure out if it was 5, 10? I mean, 10 days, 5 days? I mean, these are based on, weeks. Like, where does that come, from? That we treat everything for 1 week or 2 weeks. It just seems so arbitrary to me.
So in terms of application for clinical practice, simple UTI, 7 days should be okay. If they're febrile, you think pyelo, then you're obviously going to extend the duration.
Yeah, and they've done this with women, and they've gone down to 5 days for some antibiotics, 3 days for some antibiotics. They went down to 1 day, and then they pulled back a bit.
Right.
That
was about 20 years ago.
Yeah.
All the studies
All
were
the way down to
10,
1.
10, 7, 5, 3, 1.
And then they came.
And they backed off on the 1 because they went to 3.
Yeah.
Although 1 day of antibiotics took care of the majority, it didn't take care of all of them. So
The other underlying issue is why these men have a UTI. I mean, we know in women it's common, and older men, not at the VA. There was the issue of
Prostate.
prostatitis. I can tell you, my practice, if I call my urologist about these and I've stopped calling, that's 6 weeks of antibiotics. So I'm fine with 2 weeks.
6 weeks of antibiotics for urine infection in men.
Now,
Oh, VA.
That's interesting.
Which is this? Now this was a VA study, right?
This was a VA study.
So would you send this article to your urologist, or would you just sort of not?
No contact.
No, like, because sometimes it's like, should we be doing that?
But it does bring up a really good point. Another plug for ultrasound. I can't tell you how many of these patients where you get the male UTI and you pop an ultrasound on, and sure enough they have hydro or like a big big bladder. They have urinary retention. That's the reason the UTI is there. So it's a good point on top. What's
I
next?
just got a call.
Do you have a call?
Yeah, I did.
Was it the VA?
No,
The
no.
urologist? He's saying, I'm convinced. I'm going to 2 weeks.
I should have turned my phone off, but my car insurance, for the warranty is
Yeah.
extended warranty. So you'll gotta excuse me, please.
What, did they tell you in English, or was it a different?
Anyone you
Nah,
want.
yeah.
Are we up to
33?
Nice.
Oh, I like this. Management of simple febrile seizures at U.S. children's hospitals. Children's hospitals, you would think, they are the experts. They are the leaders. They should be teaching us what to do. And whenever you see these papers, it's like, what are you thinking about? In any case, they want to know before and after the American Academy of Pediatrics came out with guidelines for simple febrile seizures. They looked at 49 tertiary pediatric care hospitals in the United States of America, and a huge number of kids, 50,000
Big database. Yeah.
50,000 before the guidelines, and then 90,000 after the guidelines. And obviously, this is a database kind of thing. Looking at, well, you can easily follow, do they have a lumbar puncture in a database? Do they have a CVC in a database? It's black and white kind of thing. So as you might envision, the numbers of lumbar punctures just plummeted from 10% to 0.6%. 0.6% is like 1 in 60, 160. I'm surprised it's that many. But anyway, 0.6%. Reductions in CBCs was from 40% down to, what was it here? 40% to 10%. Head scans, my God. Head scans went from 11% to 1.6%. That means like 80 kids, 1 out of 80 febrile kids is getting a head CT. Anyway, they went down everything that in terms of charges, everything's cost less. no significant change in delayed diagnosis of bacterial meningitis. The incidence of bacterial meningitis in the pre-period, 2 per 50,000. That's this literature on doing lumbar punctures it's going to be rarer and rarer
Yeah.
and rarer that you do a lumbar puncture. And one of the concerns about that is, how good are your residents at doing lumbar punctures?
It's such on the CORD listserv, which is the council of residency directors all across the country. There's a bunch of stuff coming up right now about, hey, how are you guys getting enough numbers for your residents to get LPs? You know what? The number that they're supposed to do over 3 or 4 years is 10. 10. And a lot of places
that
aren't
in
even
adults?
getting 10 in
Adults and kids?
LPs, period.
Really?
And there's places that aren't even getting 10 over the course of 3 or 4 years. The way I think a lot of it is driven by the subarachnoid studies. People are doing more CTAs, less LPs in kids, but
Well, you know, when you get in these studies that say, well, the number needed to treat or another number needed to test is 500, and when you're looking in these, even these kids in the first 2 months of life, or in the first, skipping the first week, the numbers are just astronomical. You really want to do 500 lumbar punctures to find one case?
The harder question for residency directors is how many do you have to do to be competent? And where did they come up with the number 10? I'm just going to guess. But, you know, and so we've moved to a competency-based system of promotion. And once you're competent doing it, once you've demonstrated competence, and we know different residents, for some residents that's a few, and for some residents it's like,
need 30.
You're not there yet, right?
Yeah, but
so,
think about that. I mean, if you're looking at competence, it's like, okay, let's define it as a non-traumatic tap that you got into the CSF. You didn't hit the ureter, you didn't hit anything else, you just got into the CSF.
Aorta.
Yeah, the aorta. You can get lucky and hit 3 of them.
I think you got to have some real skill to hit the ureter.
It depends. I've seen liver biopsies from the. But the reality of it is, you can just get lucky on your first 3. I mean, yeah, and it happens to be.
how do you know it was luck?
Well, but that's just it, though. If you didn't follow them out, let's put it this way: what study would you ever accept that only had 3 patients, and then you said, "Oh, geez, you know, this medicine works"?
None. But
Yeah.
how many? How can we artificially say 10? And that's dichotomous as, oh, you can't graduate. You've got 9.
Actually, the anesthesia literature actually has, because we looked at this once, and they have really robust data on how many procedures it takes to do epidurals, intubations, and those kind of things. And you know, they have these curves that map out. And I think competence was defined as you were able to get it within 1 try, 2 tries, whatever it was, whatever they decided was the best thing. And you could see, like, intubations, it's like by 10, the thing goes straight up like this. Spinal epidurals, it's a much shallower curve, so you're way out of, you know, you need 50 to be able to be really good at it.
But that's on a population, not on an individual.
Correct.
Well, this paper is, you know, it's one of the few, like, we're doing things the right way studies. We should congratulate ourselves for this one. This
Yeah, I
is good.
think one of
trends
the
are good.
concerns about learning how to do lumbar punctures is having patients who it's appropriate in to do those.
Yeah.
And they're fewer and far between.
We looked at, I just tapped an 8-week-old the day before I came in here, and we looked at the data on it, and our docs are very interesting. The older docs who were practicing prior to the Prevnar vaccines and whatnot have a very low threshold for tapping, because if you missed it, you didn't get another shot. You missed a strep pneumonia or an H flu meningitis. You know, that kid you discharged him at 9 in the morning, they came back dead at 6. So they have a very low threshold for doing it. The younger docs who've never seen these diseases have a very high threshold for doing it. So you'll see when we look at over the course of a year, there's 3 of us that tap, you know, 5, 6, 10 kids, and there's 0 for anybody else, you know. And we have found, one of the best ones we found was the 2 pediatricians brought in a kid. It was one of the pediatricians' kid had a fever and whatnot, and I forget how many, 10 weeks old or something like that. And it was a Sunday, so one of her partners from the practice, they came in, they said, listen, this Sunday, we just want a CBC on this kid. You know, we already straight catheter for urine. She's had a fever for a couple days, you know, this smoldering thing. And the nurse who was, it was a Sunday I was working, and the nurse I was working, said, okay, yeah, we'll put her in the room. I'll grab the CBC for you. And as soon as she laid the kid down on the stretcher, the nurse just, and an experienced nurse just looked up at me with this look in her eye, like,
You know that look.
this is, yeah, you've seen that look before. It's like, I'm scared. And so we argued with them for like 15 minutes, like, this kid needs a tap. And finally they were like, okay, fine, just, do it. And of course, kid had meningitis. And so you do get a false sense of security where these two younger pediatricians grew up in an era where they didn't see it that much. The weird thing about it is the kid's meningitis was Pasteurella. And it's the second case I've seen with Pasteurella. The first one I missed. The second one I saw it, and it's like the first one came from, they blamed the dog, but it was actually the kid had a hemangioma that he would suck on, and that's how, and he inoculated himself. This one got it from the cat licking the kid's head. I'm like, come on, who lets the cat lick the kid's head? But anyway, yeah, and they made him lick it over the fontanelle, so it just kind of saved it.
But this is so interesting about like the psychology of medicine. I mean, you can have all the evidence in the world, and it takes an N of 1 of a bad experience to kind of like supersede all evidence. And
Personal anecdotes are powerful.
Yeah, the
They are
evidence just left the building.
Yeah. But it does show you that you're exactly right with what you said. If you're not seeing the diseases, you're not worried about them. Like none of us here are all that concerned that a rash is going to be measles.
Vaccine.
Yeah.
Interesting.
All right, where are we?
34. So this is the risk of TBIs, traumatic brain injuries, in infants younger than 3 months of age with minor blunt head trauma, published in AEM. And we have these prediction rules, right, put out by PCARN, and they're dichotomized into kids older than 2 years of age and kids younger than 2 years of age. This study wanted to look at, how about in the under 2 years of age group, the really young ones, the 3 months and under. And so they looked back at the database, so it's a secondary analysis, so a low level of evidence, and at the kids who did and did not meet the PCARN data for getting a scan of the head and looking for those things. So in the whole cohort of under 2 years of age, they had 11,000 children in that original cohort, and about 10% were under 3 months of age. So, about 1,100 kids, about 1,000 kids, right? And what they found was if they met the PCARN low-risk criteria, right, only 0.2%, right? 1 out of 514 children, a really small amount, had a clinically important traumatic brain injury. So it seemed to work well. Now, some of them had traumatic brain injuries, right? And that worked out to about 5%, but you wouldn't do anything outside of watching them. It wasn't a clinically important traumatic brain injury. And even the same amount, 5%, had skull fractures. Using that in the under 3 month age, using that PCARN rule for low risk. And so they conclude that traumatic brain injuries that are clinically important, these children are at low risk, and this PCARN clinical decision instrument can accurately be applied to those little ones as well, under 3 months of age.
This is such an interesting subgroup that's less than 3 months. I have a case that is a personal case that was just emblematic of all of these numbers. We had a family, this was tragic, a family, mom and dad with their 3 kids got into a bad car accident. The mom dies on scene. The dad has injuries, and then the grandma comes to be with the kids, and the kids look fantastic, and they're sitting in our PZD, like highlighters. They don't even know what happened to their mom. So the 2 older kids, the 7-year-old, 4-year-old, are just in there coloring their books and just hanging out, kind of unaware of what's happening. And then there's a 2-month-old that's sitting there that was secured in the car seat, looked great, observed, evaluated multiple times. And the grandma came to be with the kids, and finally we were like, this poor have the grandma go home with these kids. And we ended up finding car seats and discharged them and whatnot. And I think it was about 8 or 9 hours later, the little one ended up having a seizure, ended up getting transferred to one of our sister county hospitals. had a subarachnoid, had a small skull fracture, ended up being exactly this cohort of 5%, the CT positive skull fracture. No intervention was done, but it was a miss, and we spent quite a bit of time talking about this in our educational rounds about the observing like 2-month-olds or 1-month-olds. It's so different than observing like a 7-year-old or an 8-year-old who can actually tell you, I don't have a headache, I don't have that, I feel great. But like a 2-month-old, a 1-month-old might not be able to tell you.
Well, time is a great diagnostic tool. Absolutely, giving patients a tincture of time to declare themselves is a wonderful diagnostic tool.
We did, yeah, but several of us had. And the kid was just...
But he did say that they had a skull fracture and no intervention was done, right? And so that fits into
It was a hairline, non-depressed.
Yeah, this fits into 5%, right? It's not going to be 0. And so this is the conversation you have with the parents and caregivers and say, listen, we've examined your child. They're at low risk based on this thing. And there's, like a really, really small risk, not 0, 1 in 500 in this case, of having a clinically important. But there's a 1 in 20 chance that they could have a skull fracture. And we would not be doing anything because of that skull fracture. And how would you like us to proceed with that? Because if they were high risk, right, you see the numbers jumped to high risk, 20% had a clinically important traumatic brain injury. Wasn't it? No, sorry, 4% had a clinically important traumatic brain injury.
Positive CTs.
And 20% had either a skull fracture or a traumatic brain injury identified.
But the way that's changed my practice, like a case like that, is if there are obviously fatalities or even severe injuries, like there's an emotional toll that happens where you have like, how's this poor grandma probably like thinking about her daughter just died? How's that person in any way effectively going to observe her child? So if I have these like bad car accidents and things, I don't know how many of you work in a trauma center, but for us, I have a pretty low threshold to like have that patient like observed.
Observed.
Yeah.
Yeah, not necessarily scanned.
Right.
And parents love it when you come
Admit for
back
observe.
and say, listen, I just want to take another look. Do you mind just staying around for another hour or two and we'll just see how they do, and I'd love to take another look and just let's make sure that they're okay and do a second exam. I've never, parents usually go, no, we're fine, and leave. Now they can, but usually like, I'm concerned about your child. I care about your child. Clearly you do too, so let's take another look. I don't know, Al, you see more kids than the rest of us.
No, I'm a huge fan of sitting on the kids. Yeah. Oh, absolutely.
Sitting on the young kids.
Yeah, I mean, and our
That's what the algorithm
departments
says, right?
Yeah.
The algorithm says just shared decision making and observe is a reasonable option.
Our ER sets up that the cribs sit right across from the main nursing area, and it's not just you that's keeping an eye on them, everybody's keeping an eye on them. And you walk by and the kid's coloring or the kid's behaving or they're rattling the crib like, come on, I want to go play in the needle box, let me out of here. So yeah, I am huge for that. I get very concerned with people who can make snap decisions on these kids and just like, oh yeah, they're fine, they can go home. It's like, yeah, I don't believe it.
And it's nice documenting 2 separate exams on these children as well. That's something that I do, and I time code it in and say, now I'm taking another look at them. And they're still this or they're not that or whatever. So
for this infant, that patient was observed for about 8-9 hours in our ED. And then discharged. And then discharged, and then ended up having.
And unfortunately, they went to another center and were scanned, and they found a
better,
skull fracture.
A better hospital.
Yeah.
A better.
Number 35, I don't know what to make of this paper, and I'm going to get Raman's and Ken's input on it.
I'm going to give input.
Yeah. Rick can chime in if he wants. This is, they looked at isolated traumatic brain injury and routine intubation for Glasgow Coma Scale of 7 or 8. And it's a retrospective look at a trauma registry, but the thing with trauma registries is the data is collected prospectively. So when you do a retrospective look at a trauma registry, it's really a prospective study in a lot of ways. And they looked at people with Glasgow Coma scores of 7 or 8, who either went what they called immediate intubation, which was less than 1 hour of admission, delayed intubation, greater than 1 hour of admission, or no intubation. And they did a multiple regression analysis, and they looked at it. 68% were intubated within 1 hour, which is probably what most of us would do. 8% at greater than 1 hour, and then 23% were not intubated at all. And then they did all the numbers, and what they found was that indeed, patients with a GCS of 7 or 8 and isolated head injury, immediate intubation was associated with a higher mortality and more overall complications. my
So
first
intubation
response-
causes death.
Right. My first inclination was the ones with immediate intubation were sicker. I'm not sure what other parameters they were collecting because these were isolated head injuries, but they must have been sicker because as soon as they hit the door, they were getting intubated or they were intubated in the field or whatever. Now, if they're intubated in the field, that has been shown to increase morbidity and mortality because prior to end-tidal capnometry, they were hyperventilating these people or hypoventilating them, and they wound up with secondary brain injuries as a result of the intubation itself. So they didn't say whether they were intubated in the field or not, but if they were intubated within 1 hour of the emergency department, I would think that my own experience is somebody with a Glasgow Coma scale of 7 or 8 is not somebody I'm going to just sit around and watch. And so is every GCS of 7 or 8 the same? Or was there something about the ones that didn't get intubated? Because the ones that got intubated right away, I think that's a lot of pre-hospital stuff, and there's also, they were just obviously really sick when they hit the door. What was it about that 23% that didn't get intubated, that just got watched? Did they go to an institution where they were less aggressive? Was there something about them that's like, hey, it looks like they're getting better? You know, were these 8s just about 9s? I don't know. But to me, it just seems kind of funny that if I see somebody that sick that I'm reaching for a laryngoscope at the time that they hit the door, I would think that I'd feel a whole lot better intubating this patient, particularly if you're at a site that's got to ship them out somewhere, that you would feel a whole lot better intubating them than sitting on them and watching them. I don't know. Well, at the county, what are you guys doing with these bad head injuries?
We have so many GCS 6s, 7, 8s that come in all the time, and I think that we have a lot of illicit street drugs. We work over at Skid Row, so you see just a potpourri of different meds on board all the time, and we don't routinely intubate our 7s and 8s, but we do have. I think there's so much heterogeneity in that type of patient. There's the agitated, I just got hit with they have a big Goomba on their head and they're agitated, like intubate and get them to CT. The question for us oftentimes is, do I need to intubate them for them to be stable enough to get the CTs to see if there's anything actually going on? And to me, it sounds like the cohort that got intubated because they were either more agitated, more sick, and then it turns out that the ones that got intubated because they were more sick, agitated, etc., were more sick than the cohort that didn't. It makes so yeah, I mean, we're also fortunate. I think there's a difference. I work once a month at a community shop that's single coverage. My threshold for not intubating at a trauma center where I have like so many resources and people available and we're observing very closely is I can watch that patient a lot more closely and observe for longer periods of time than maybe in a community hospital where I'm not sure I have to transfer someone. Maybe my threshold would be a little bit lower, but yeah, I think all GCS 7s, 8s aren't created equal. And
well, that may be the problem in the study too, because you've got all these different institutions putting data in, and what I call a GCS of 8, you might call a GC8 of 10.
See, and that's the point I was going to make.
that's
The
also
inter-rater reliability and intra-rater reliability for a GCS score is fuzzy, right? So is every 8 an 8? Is my 8 the same as your 8? No, probably not. They did try to control for age and severity of head injury,
Right.
drugs on board, substance abuse or not use, substance use and alcohol and stuff like that. But you can't capture everything, right? And you can't capture 20 to 30 years of clinical experience going, yeah, I don't care what the GCS is, I'm intubating this one. Or you know what, they've just got a whole bunch of ketamine on board recreationally, and they've got a GCS of 3, and they also bonked their head, so they got into this study, right?
Well, I think the other part of it is, if you had a GCS of 8 and you have a big epidural hematoma versus a GCS of 8 and a diffuse axonal injury,
They're different.
They're way different.
Yeah.
One's going to go to the OR and get decompressed, and the other's not. The other thing with GCS, and you mentioned this, kind of fuzzy. How many times, and Raman, you can answer this. How many times do people? It's kind of like ABGs. It's like, yeah, it looks like a 7 or 8. Yeah, it's not like
They didn't even
okay,
formally do
yeah,
it.
Exactly, exactly.
It's funny you mention it because one of our senior residents who's been, they spend so much on an 8-hour shift or 12-hour shift. they're sitting there calling out GCSs over and over and over and over. And this resident came to me and said, "Can we do a QI thing where we actually put like the three things? Because sometimes like." She's like, I have like 3 numbers. I either make it like a 15 or like kind of an 11-ish or like a 7-ish or something, and I just kind of go with one of the.
Or do I want to intubate them?
Yeah.
Do I want to, so they're a 7, right? I don't really want to intubate them. Oh, I think they're a 9.
Yeah.
You know, I think I could understand what they were mumbling. So like, it may not just be inter-rater reliability. It might be driven by the clinician's desire to either intubate or not intubate that individual. Oh, I don't really want to do. Okay.
Yeah.
Right.
But I think that the main thing is the number one thing that's going to drive it is going to be the nurses. If you've got the 7 or 8 that's just laying there, it's like, yeah, fine. If you got that 7 or 8 that's
Thrashing.
rammy and agitated, it's like, no. Doctor, I'm worried about their airway. You better get in here.
I want to make sure we don't confound, though, that like these patients are not all getting intubated, but GCS 7s, 8s with like head trauma, like generally are always getting, you know, you'd have to have a really, really strong reason not to scan one of these guys.
Right, yeah.
Oh, God.
I just want to make sure the message doesn't get lost or confounded.
Yeah.
All right, number 36, the prospective validation of the Canadian TIA score in comparison with ABCD squared and ABCD21 for subsequent stroke risk after transient ischemic attack, a multi-center prospective cohort study. This was done by Perry et al., the famous
group?
Perry. Yep, this is a very well-known research group over in Canada, who they had a derivation study prior to this where they came up with the Canadian TIA score. If any of you have ever, I don't even think it's on MedCalc yet, but it might be. The derivation study, it's a 13-point. I mean, it is pretty complicated. You need a calculator to derive this thing. It's not as simple as these.
My note on that one says need MD Calc.
Yeah.
You do.
Yeah.
Is it on there?
No.
Oh yeah, I didn't think it was on there yet. So it's a prospective cohort study. This is the validation part of this clinical decision instrument. They enrolled 7,607 patients with TIA or minor stroke. They looked at a primary outcome of did these patients have a subsequent stroke or did they have some major intervention like a carotid endarterectomy with stent within 7 days. And they basically took their own all these patients got an ABCD squared, an ABCDI, and a Canadian TIA score, and they looked at, well, what are the performance characteristics of these different tools for predicting these bad outcomes, and in their study, they found that the Canadian TIA score fared pretty well, that their low-risk patients, there was only about 0.5% of having these terrible outcomes, and their moderate risk, medium risk patients, 2.3%, and their high risk scores, they had 6.3% rates of adverse outcomes. And so this is great. It's great that there is a tool. This tool is by no means simple. And when you don't have a simple tool, and it's also a complex disease process, TIAs, minor strokes.
It's not an ankle injury.
Yeah, it's not a very straightforward thing. And it was internally validated within their Canadian system. But before I would apply this at my shop or any other shop, I would like to see some external validity, some further study on this. Because like Ken said yesterday,
I predict.
That these CDRs start out really good and promising, and then you start applying them in Italy, and you start applying them at
And
multiple
nothing against
sites in the
Italians.
US. No, it's not just the Italians. It's not because.
Yeah, we most of ours are decided over a bottle of Chianti, so we're just fine with this.
So anyway, a interesting tool that was developed by very smart people in Canada by a very talented research group. But
And they
still,
concluded that it was ready for clinical use, and I would agree it's ready for clinical use in Ottawa and Kingston and the surrounding 13 sites that did this study, but not necessarily in my site that's just down the street, by 6 hours, because we haven't been running this. We're not so familiar. We're not, all focused, and I would make I'll put my nickel down that it will not be as robust in further validation studies if they're done.
Well, we saw it with the Canadian syncope score. We saw it with all these scores. They look good internally, and then you try to apply them.
The only one that's held up, really, really well is the Ottawa ankle rule.
Well, putting nickel down,
Yeah.
we'll talk about number 37.
Do you want me to take a break and leave?
Is this the, is it,
I have a few things on this one.
oh, Ken's been talking about this study for 3 days.
I get
Yeah,
just
we've got
just
15
thinking of
minutes
this thing
left,
here.
guys, so,
do it.
yeah. This
All right,
ought to
so
be
here
good.
you go. New England Journal,
Here we go.
everybody bow your head. They're looking at how these mobile stroke units do compared to regular EMS in dealing with strokes in terms of their outcome. When I first heard about these things, my response was, you got to be kidding. But no, they weren't kidding. These things are $1 million a piece, and plus
$1 million to
staffing.
operate.
Yeah, you have to staff them all. And how many can you have in your community? And in Los Angeles, you're not going to get from Burbank to Glendale, at 5 o'clock, no less with this machine here, for crying out loud. As you can see, I'm really quite positive about the concept. In any case, they enrolled a lot of people, 1,500 people, of whom 1,000 were eligible for TPA, 2/3 in the mobile stroke unit and 1/3 in the EMS units. And they looked at how quickly people who were eligible for TPA got it. And it was 72 minutes versus 108 minutes. So there was a 40-minute absolute difference between the two. Now, do you intuit that 40 minutes would make a difference here? I don't know. Of patients eligible, now here was what I thought was the hooker. Of patients eligible for TPA, 97% in the mobile stroke unit got it, but of patients eligible for TPA in the EMS program, only 79% of the patients got it, which has got to be, well, if TPA works, which you're not sure about that, it was substantially less. It's almost 100% versus 80%. And how do you expect people to do if you think this therapy works if you're only giving 80% of them the medication? When they looked at things like these Rankin scores and the like, they seem to be a tad higher in terms of improvement with regards to the mobile stroke unit. When they looked at mortality was 3% different, 8.9% versus 11.9%. That seems like a big number to me.
Yeah, there's no TPA literature that shows mortality is better with TPA.
So they like it. And there's other studies where they have, when you have something that you've invested a lot of time and energy in, you got to show that it's worth the $1 million for these ambulances. Plus, who's going to staffing these things? The TPA is being given. You have to communicate with the CT scan results to somebody over some radio.
No, they usually have a neurologist in there.
Right.
neurologist.
Sometimes.
Oh, I thought they had the
No.
early ones had a
The
stroke
early one-
neurologist.
yeah, and part of the primary, one of their primary outcomes, I do not think of that word means what you think it means, primary, but one of their 3 primary outcomes was the difference between having a neurologist on board and not on board. And they published that study a couple of years ago saying it didn't make a difference.
Of course not. The neurologist didn't want to ride around on an ambulance.
So they
Yeah, 'cause
proved
you
that
can't
they
get an
don't need to
MRI
ride
on
around on
it.
the
All
ambulance.
right, so if I put the volleyball up there far enough for you to do the slam.
What do you, Jen-
I would cede the floor to the
What do
honorable
you,
gentleman from
gentlemen?
Canada on this.
Yeah, we
No,
can see our time.
Yeah, I see my time is coming up. No, I did an episode, I did a critical appraisal in an episode on my podcast on this with Howie Mel, who's board certified in emergency medicine and EMS. And we looked at it, and the conclusion was that the juice wasn't worth the squeeze. They haven't published their cost-effective analysis, which was one of their 3 primary outcomes. And so, I anticipate they will publish their cost-effective analysis eventually, but they did publish their analysis now using something called a utility weight modified Rankin score, which is different than your normal Rankin score. They put a certain weight to each level and then adjust it and stuff, so there's some more play in that. The original primary outcome, when you go to clinicaltrials.gov, whenever you read a trial, if they've been registered, you can go and say, what did they plan to do? And they plan to see what was the time to treatment, what was the agreement between the on-board neurologist versus not on-board neurologist, and the third one was cost-effective analysis. None of those were published. in the New England Journal article. But they did update their primary outcomes subsequent to them registering the trial, and it was supposed to be the change from baseline to after treatment at 90 days of their utility weight modified Rankin score, and that wasn't published either. So of course I called up the lead author, because that's what I do. Oh my
Well,
God.
if my
it's-
caller ID ever shows up with
He's like, oh my God.
Unknown number from Ottawa. Could not pick up.
Call display, it's Ken. It's like, oh, he was very nice.
So maybe
we-
somebody from the
What a
IRS
pain
will
in
call
the
out.
butt calling.
He was very nice. We had an email exchange. I didn't call him. I emailed him and contacted him and congratulated him, of course, on getting his study published in the New England Journal of Medicine, and was just curious. When I was reading through, I didn't see that they published their primary outcome, and where were the other outcomes and stuff. And he said the cost-effective analysis is coming. We did publish the on-board versus off-board, and didn't tell me why they didn't do the original primary outcome of a change. They just published the median or mean at the end. And after a couple of emails, he no longer responded.
What was interesting? How about this? Like that you brought up this fixed cost bias. Is this ready for prime time?
Yeah. So one of the things is I'm going to do another show on once you put a whole bunch of time and money and energy into something, and you brought this up. We spent the $1 million. It's spending $1 million a year to operate this machine for a very narrow slice of patients. And there's a bias that you can have, which is, an investment bias, where you've invested so much time and effort or money into it that you're biased towards finding that it works, right? And we can all understand why you would do that. And we want this to work. Like, we do want our stroke patients to do better. I mean, of course we do. We all want. That's our common ground. But, Howie said, for $1 million as an EMS director, I can get 3 ambulances for that, operate them all year round, and you know what kind of emergencies they can respond to? All of them, right? Not just stroke patients who may or may not qualify for TPA, right? And you remember, not every patient who gets TPA, even if you believe that NNT of 10 or something like that, does well. So you're talking about spending a lot of money, and as emergency clinicians, we treat anybody for anything at any time, and so we look at things generally, and it's not a completely open-ended system. And as a subspecialist who's a stroke neurologist, I understand their point of view. They look at, I want to do everything I can for this patient, this stroke patient, and I want to do everything I can for all patients. That's all I have to say about that. How's that?
The only thing is, when you look at the cost analysis of this,
They haven't yet.
But if you put three, and
Oh, the back of the envelope, yeah.
yeah, Howie's points, and Howie's really, really smart.
Oh, yeah.
But one of the things you have to take into account is, what is the long-term cost for somebody with a debilitating stroke that spends 10 years in a chronic care facility versus, how many millions of dollars does that add up to? Mm-hmm. Versus, okay, I could put 3 more ambulances on there and we would have picked up a bunch more people with gastroenteritis and whatnot. So,
but those other people still would have gotten TPA and maybe 40 minutes later, and
correct.
Would that have made a difference anyways? And that presupposes that TPA works, and it presupposes that time is brain, which Dr. Gomes, who was the original person who coined the term time is brain, has walked that back and said that's not an absolute paradigm. So
right, but my bottom line for this would be, if I was going to look at it, would be at 90 days, what's the modified Rankin score? Mm-hmm. Where are these people? If it turns out that these units, the first time I heard about it, and there's only one in our state, and I think they parked it in the wrong spot, and the people took the wheels off it, and that's the end of it. But it's New Jersey, come on. But the reality of it is, I think, if it turns out, and I think you have to give it time to turn out that having this unit at 90 days has people with a better modified Rankin score, and they are living at home and they're not in a chronic care facility, the cost may balance out on it.
Yeah, it may, and the trouble with cost-effective analyses is it all depends on your assumptions, and so you're looking at stroke morbidity and mortality,
right?
And so you have to compare it to everything else
correct.
That wasn't done.
Yep.
That was delayed, or the MI, or the trauma, or everything else that if you had 3 trucks on the road seeing them.
That's true. But
So
I
it gets
think-
complicated.
Oh, it gets very
Like
complicated
I-
because you could make the argument, well, if there was a delay in getting to a COPD patient, how many of them wind up in a chronic care facility?
And intubate,
Yeah.
yeah, no, so it's difficult.
Yep,
It is a challenge.
And I think the other part of it is where you set your barometer. And I think when I look at more the thrombectomy, more of this thrombectomy data, and at our site, more at a comprehensive stroke center and whatnot, seeing better outcomes with these thrombectomies. And I think the one thing that's really become clear is this arbitrary number of 4.5. What we're seeing now that we're doing these CT perfusion studies and everything else, there are people who have, they're 20 hours into their strokes, but for whatever reason they have enough
Great
little,
collateral flow.
yeah, and
Yeah.
whatnot. So it gets more difficult. So what you're going to wind up with is, I don't just want to set this unit up with a CAT scan. Now I want it to have CT perfusion and
angio, one
CTA and everything
Well,
else.
they're looking at getting the MRIs in there, but they can't make the ambulances out of metal because they turn it on. But
Only one
a
trip.
plexiglass Pope mobile or something made out of some polymer.
We got 7 minutes.
Sorry.
What do you think you think we
Yeah,
can
no,
attack this next?
I'm trying not to monopolize stroke. So antiplatelet therapies for acute ischemic stroke. This was a Cochrane database systematic review. They tend to do very high quality assessments with great methodology. They looked at randomized control trials to figure out, should you be starting aspirin or ASA, immediately on people with presumed acute ischemic stroke, and the answer is yes.
39 is a repeat computer tomography for anticoagulated patients with an initial negative head CT. Don't need it. They looked at 1,000 people or so with a negative initial, 1,600 people, negative initial CT. They CAT scanned them all again 6 hours later. 12 of them developed an intracranial hemorrhage that was identified in the second CT. 3 subdurals, 2 subarachnoids, and 1 intraparenchymal. None of them wound up with a change in mental status that required any intracranial pressure monitoring or underwent any neurosurgical intervention. The only thing that really scares me about this is none of them developed a change in neurologic status, which means if you're just going to watch them, you're going to miss these anyway. But if you miss them, it doesn't matter. So
Back to the clinically important stuff versus not. We'll review this in the trauma lecture as well, the same kind of path. The next paper is number 40. That's suicidal ideation is insensitive to suicide risk after emergency department discharge. Performance characteristics of the Columbia Suicide Severity Rating Scale Screener, published in Academic Emergency Medicine recently. So a little background here. JACO recently put out a recommendation mandate that suicidal screening needs to occur in emergency departments. Now, it's a really nice idea and it's a really important idea. The problem is we have no great validated screening tools, and this was an attempt to look at one of the more well-described screening tools, the CSSR. And yeah, the bottom line, as Ken mentioned, I'm going to just kind of dive into how poorly this works. 92,000 patients. Out of the 92,000 patients they looked at in this registry, 11 patients died by suicide. That's 0.01% of these 92,000 patients. Only 11 died by suicide. How many did this screener pick up? Out of those 11, it had a sensitivity of 18%. It picked up 2. Only one of the patients had a psychiatric assessment as a result of, of those 11 patients,
So
9
it
of
means-
11 screened negative, and only 1 had a psychiatric assessment.
So I'll just put trigger warning. This is sarcasm. So clearly it needs to be made into a quality metric,
I mean, it's impossible right,
right?
now.
Clearly we have the data that make it into a quality metric.
Well, the other part of it is, and this is just from a operations standpoint, how long does it take the nurses to go through?
Well, I think it's a multiple.
Yeah,
This is a,
and you see them. There's somebody with pulmonary edema, and they're asking them, do you feel safe at home? Do you,
right.
Yeah.
You beat your wife.
No, but the other, and it's an important topic, obviously, right? But they'll say, well, it's not that much, and we can computerize it, and we can make it easier to do. But that's combined with every other screening thing you have to do. And by the end of it, you've got so much bulk that you're waiting 30, 40 minutes for triage.
Right.
yep. What's your blood pressure now? Oh, it's 70? Sorry about that.
Yeah. So
Well, the other thing is for the people who don't have life-threatening problems, this is unnecessary, unasked for questions that
91,900 people got screened that didn't need it, and the 11 people that needed it didn't get it. We're skipping a step here. Before you make these mandates for screening, we should at least have some form of tool that we know
high-quality data that works.
it can work. Yeah.
other than that.
Interesting. All right.
41.
41 is about giving antibiotics to people who have diverticulitis, mild, acute. And I think that this is interesting because this is such a large study. 15 hospitals were involved. 242 patients got antibiotics. 238 did not get antibiotics. And they looked at, hospitalization rates and revisit rates, poor pain control rates, and they were there was no clinically significant difference between these numbers, and they concluded it. Non-antibiotic treatment of mild diverticulitis is safe and effective. It is not inferior to what is standard therapy, which is giving these antibiotics. Taking the point of view that this is kind of like appendicitis. In appendicitis, you may have a blocked up appendix. You get an infection in those blocked up appendices, and so that's called appendicitis. A gallstone blocks up your gallbladder. You get an infection behind it. Something blocks up your sinuses, you get an infection behind it. Something blocks up your eustachian tube, you get an infection behind it. So the same pathology, maybe something blocked up this little pocket that you had there, and as a result, you got an infection behind it. So it was so logical to give antibiotics for all of these conditions, and people now are getting weird and saying,
Well, it just shows you the natural history, right?
we don't need to do that.
But the natural history is if you have mild, uncomplicated diverticulitis, most people will do well. Would you like antibiotics for this? Right? Like, shared decision making. We have good evidence now that, you may not need antibiotics. Do you want antibiotics? And if they're like, oh, every time and I get a yeast infection or I get antibiotic-associated diarrhea, and then there are other people like, oh yeah, no, give me the antibiotics. So you've got shared decision making. Both are reasonable and I'd support.
Yeah,
Well, all these studies. Oh, sorry. Go ahead.
Yeah,
No, go ahead.
Yeah, I was going to say all these studies have come out of the ones that have compared no antibiotics to antibiotics, and everybody's been CT'd and CT confirmed diverticulitis. Have, as far as I know, have come out of like Europe and Sweden, and now this is Spain, Danish, like very different diets than we have in the West. I don't think that
And
it would
patient
not
expectations.
work here.
Yeah.
And different patient expectations and follow up and all those other things. I would love to see an RCT on this in a Western population to see if this
good
would
point.
this would apply.
Yeah, they did a bad job with the acronym too. The better one is the study before it, which was the Diablo study.
Diablo.
Yeah.
This was Dynamo.
Yeah.
Yeah, 42 is we are NOTA gonna take out your appendix, sticking with the Italian thing. NOTA, right? Non-operative treatment of appendicitis. And I've been sitting down with patients saying, listen, if you've got mild, uncomplicated appendicitis, you have the option when you're talking with your surgeon. I don't make the decision, I prep them for the decision, that the surgeon may suggest not operating and just giving you antibiotics, and that's reasonable, but about 25% will have their appendix taken out in the next year. This gives some more information and maybe better numbers to say actually the number is closer to 40% in the first year, and about half of people will have their appendix taken out within 2 years. And so that's shared decision making. Do you want to have your appendix taken out now, or do you want to have it taken out in the next couple of years? Is now a good time for you? Can you schedule this in, right? Or is another time better? And I let them decide with their surgeon.
Well, do you guys remember the 2014 Rafael Nadal was playing in the Shanghai tennis tournament or whatever, and he got appendicitis and he opted for antibiotics.
He said, load me
finished
up,
the tournament
and went home and got it taken out.
and then got it taken out a month later.
The for the ruptured
Is he the
appendices
anti-COVID
too,
guy
they're
now?
also
I don't know.
my son-in-law had a ruptured appendix, and they're not operating on them either. They're just giving them antibiotics, letting it cool down, and then they come back. Then they gave him the option when they said after like a month or so, they said, you want us to take it out, or you want to just wait and see if it happens again? He opted to have it taken out electively at that point. Speaking of appendicitis, magnetic resonance imaging for appendicitis, it works.
Okay.
Not great data, but it works.
All right, I'll read the last paper. 44, proton pump inhibitors, PPIs, prior to endoscopic diagnosis and upper GI bleed. Another Cochrane review sort of reinforces what we already know, that they looked at PPIs in upper GI bleed patients prior to endoscopy and found that there's no real mortality benefit, no big changes in need for surgery or rebleed. The one thing that it did change, and again, we talked about patient-oriented outcomes or not, the one thing that it did change is there was less need for endoscopic hemostatic treatment if patients had received PPIs before. And so does that change patient outcomes or not? Unclear, but that would be the one rationale to give a PPI.
So when they call you up and you've got this upper GI bleed or whatever, and they say, have you started the 80 and 8?
Mm-hmm. I say, no, we've been, don't let that prevent you from giving blood and doing the things that actually save the person's life.
So
and ceftriaxone.
But do you say, yes, I've given the 80 and 8?
We don't, I think we gave up on it. We're just
Yeah,
giving
no, I've
one
given up
bolus.
on it, but I still get that call. I still get that from
milligrams,
surgeons.
Yeah.
Now they tend to be a little bit less. They sort of have you given the PPI or have you given the Pantoloc yet? I go, mm-hmm. I just didn't give 80 and followed by an 8 milligram per hour drip.
One dose is good.
I just give them a dose.
Yeah,
and then,
one dose.
Yeah.
Save your nurses from all the resource of having to manage the drip.
Don't you have to save that now because it's being used to treat COVID?
Oh,
Did you
No,
see
that was a good preview.
I thought that was no, are you teasing us here with a new little thing? Stay tuned.
Aren't you using that for your COVID patients
The
now?
Pepsid,
Pepsid.
80 milligrams.
I don't know. I'm
TID.
doing the COVID treatment talk tomorrow. There's
Yeah.
every day I'm
I was
getting
just gonna
an
say, you're-
article
yeah.
added to some med that just came out.
You
we're
are
gonna drop the
screwed, buddy,
early one.
because it's
Get
as
rid
you're
of the
walking up here,
Just-
2 more
just so-
articles came out.
Yeah, I looked at the data, and there's 200 either peer-reviewed or pre-publication, servers articles on COVID a day. 200.
Incredible.
You know what's actually really cool about it? If you go to PubMed and you look up articles, a lot of the articles will say, they'll give you the abstract, but you have to buy the article or something. They made a decision that 100%
Of COVID patients.
papers. Articles are available online.
Yeah.
The full text is available, which I thought was very cool.
Yep.